to you today. Our host, that is Enrico Ammirati, who is a leading voice in myocarditis. Dr. Enrico Ammirati, he works for the Gasparis Cardio Center of Niguarda Hospital at Milan, Italy, and he works for the School of Medicine and Surgery at the University of Milano Bicocca at Monza, Italy. So, Doctor, we are so honored to have you here. Thank you very much for you accept our invitation, and please go ahead.
Yes, of course. I'm sorry not to be in Medellin because I know that it is a beautiful town, and so I'm really happy to join my experience with you. So if you have any questions at the end, I hope to provide a good replies.
Thank you so much.
So this is some of the readable a recent review article on the topic I will handle, and of course we have the good review article in the New England Journal of Medicine by Cristina Basso from Padova. We are both from Italy, one of Padova and Milano. We have this manuscript in JAMA that I wrote with Javed Mosley, and most of our experience is shared in this review article. Then we have a more complex review article. It is an expert consensus document published in Circulation Heart Failure in 2020, and then we have a brief a review article published recently in the Intensive Care Medicine that is just three pages. So if you want something that is really condensed, you can look at that manuscript. And of course, we have in mind that a few months ago, this expert consensus decision pathway has been published in JACA. So it is another manuscript that that you can refer to. I'm not one of the co-authors of this consensus, but still they are valid concept. So we start with epidemiology, clinical presentation, and a case report about a case of fulminant myocarditis. So about epidemiology, the age at presentation is between 30 and 42 years. Of course, most of the registry are based on adult population. That means that likely the emerging pediatric population and adult population, the mean age at the first presentation of myocarditis can be even younger. The sex prevalence is 60 to 80%. And another important concept is that the prevalence, the incidence is relatively low, 4 to 14 cases per 100,000 inhabitants per year. And what is the main clinical presentation is chest pain. Chest pain represents about 80 to 95% of clinical presentation, while dyspnea and symptom of heart failure are present in between 20 to 50% of cases. Syncope is relatively rare, between 5 and 7%, while the most severe patient present with the cardiogenic shock account for, let's say, 5 to 7%, between 3 and 9% of cases. So we can have a look at one case of ours, and this is the case of a 51-year-old woman admitted to the emergency department due to, I'm sorry. Due to worsening dyspnea, fever, palpitation, and fatigue. 10 days before, she suffered of a sore throat, and she had common cold symptoms. At presentation, she had 70/40 of blood pressure, and she was tachycardic and with an increased respiratory rate. This is the ECG at presentation with a ventricular tachycardia, and these are the blood exam with a significant increase in high sensitivity troponin level, while you can see that the CRP is only mildly increased. There is no liver damage, but INR is slightly increased. So the first approach, of course, was this is shock, but she was at the beginning she was almost untreatable. So she received several DC shock, and she required inotropic support with norepinephrine and dobutamine. She performed an emergency coronary angiogram to rule out coronary artery disorder. Due to this condition, she was supported first by balloon pump, and then she received a VA ECMO. Once the patient was hemodynamically stable, they were able to repristinate the sinus rhythm. She was referred to our center that is a transplant center. So the patient was in another hospital in Milano, and she was transferred on VA ECMO. This is the first echocardiogram that we have at my hospital, the Niguarda Hospital, and you can appreciate that it's a non-dilated, severely hypercontractile left ventricle with mild increase in the thickness of the myocardial walls. So the first thing is performing or not performing an endomyocardial biopsy in a case like this with a patient on VA ECMO and high suspicion of acute myocarditis. Why that is so important? This is a study, an international registry of cases of severe acute myocarditis, all with histology. And you can see that the histology of giant cell myocarditis portends such a poor prognosis. So it's very important to rule out giant cell myocarditis, in my view, because the patients with giant cell myocarditis receive specific immunosuppressive therapy, and they have by far worse prognosis comparing with eosinophilic or lymphocytic myocarditis. Even if most of cases of myocarditis are caused by lymphocytic infiltration, while just that is around 72-75% of cases. Most are post-viral, associated with autoimmune disorders or associated with the new anti-cancer drugs like immune checkpoints inhibitors. Eosinophilic myocarditis are the second most frequent cause of myocarditis, and these histologies are characterized by the presence of eosinophilic cells within the myocardium, and they are often associated with the presence of lymphocytes and macrophages. Then we have a giant cell myocarditis. As I said, these are the most severe form of myocarditis, and they represent 10% of less of severe myocarditis. So you can expect that out of 200 patients with myocarditis, you can have one patient with giant cell myocarditis. In my life, I have seen and treated 3 patients with the giant cell myocarditis, just to have a rough idea of how rare these patients are. And then we have granulomatosis myocarditis, mainly a cardiac sarcoidosis that not frequently present as acute myocarditis. And granulomatosis myocarditis are the histological feature is the granuloma, and they can present also with giant cells. So the presence of giant cells is not equal to giant cell myocarditis, because patients with cardiac sarcoidosis can present with giant cells, but what is able to discriminate sarcoidosis from giant cell myocarditis is the presence of granulomas. on histology. So this is relevant to have in mind. This is a recent study, a large registry of severe patients with fulminant myocarditis, where we show with our colleagues in Paris that performing in the first 2 days an endomyocardial biopsy is better than performing endomyocardial biopsy after 2 days. So likely these retrospective data show us that knowing what is the cause of the myocarditis, what is the histology, if you can confirm the presence of myocarditis, can have an impact on the prognosis of this patient. It must be noted that more than half of patients in these large registries did not perform endomyocardial biopsy at all, and the prognosis of patients that did not perform endomyocardial biopsy was not so different comparing with the patients that perform biopsy. So this is an important caveat because probably patients that are too sick do not perform endomyocardial biopsy, and so that could justify because only maybe delayed endomyocardial biopsy was so associated with a poor prognosis. In any case, there is another Japanese study, another cohort of around 200 patients, where we see that performing biopsy is associated with a more favorable prognosis comparing non-performing biopsy. So these data suggest that performing biopsy in a timely way can be useful in the management of these patients. In my view, if you are used to perform a biopsy, due to the fact that you are a heart transplant facility, it's better to perform the biopsy. If you are not used to perform biopsy, it's better not to perform biopsy and to consider to refer the patients to a hub hospital where they perform heart transplant. Another point is not a urgent or an emergency procedure. So try to avoid performing biopsy during the night or when you do not have all skills to manage a complication like cardiac tamponade. This is an example. It was 8 p.m. in Milano when the patient was referred to us, and we performed endomyocardial biopsy in a patient on VA ECMO. You can see the cannula, the venous cannula in the atrium, and the balloon pump. And we had the double monitoring of the procedure with transesophageal echocardiogram and with fluoroscopy. So we were quite sure to be at the level of the septum. And another point that we do is to reduce the number of the speed of the ECMO. So you are sure that you have an enlargement of the right ventricle to perform the biopsy. If the speeds are too high, and you have a collapse of the right ventricle, it can be dangerous to perform the biopsy because you have a higher risk of perforation. So it's important, in my view, to have a double monitoring when you perform a biopsy in patients on VA ECMO. We generally perform with the biopsy also with the transthoracic approach. So this is just because she was already intubated and we decided to have a transesophageal approach. This is the case of this patient, and she had a severe lymphocytic myocarditis. The results of the histology was available in 3 hours. And at this point, these are the other big questions: steroids or not steroids in this case. If we refer to the only big trial published in the New England Journal of Medicine 1995, the results do not suggest that in patients with myocarditis to administer steroids. In this, the MTT trial was a comparison between steroids plus cyclosporin or steroids plus azathioprine versus placebo, and there is no difference in the overall mortality. They randomized 111 patients, but in my view, there was a big difference comparing with the patient I presented because they included patients with severe left ventricle dysfunction, but have in mind that this patient had already a dilated left ventricle. You can appreciate that the end-diastolic diameter was 64 millimeters, and most of patients had a duration of symptoms beyond 1 month. And if you look at the criteria of randomization, they could include patients with onset of heart failure during the last 2 years preceding the enrollment. Another point is that the Dallas criteria for myocarditis was reached only in 60%. So it's not uncommon to have a negative biopsy, but what is really different is that in this trial, they randomized to steroids patients with long history of disease in more than 50% of cases. Another point is that these patients were randomized in the 80s. Most of them were in the 80s of the early 90s. And at that time, there wasn't such a huge use of temporary mechanical circulatory support. So most of these patients died if without a temporary mechanical support. While now we are able to make survive patient with the mechanical circulatory support. So it's even more interesting to know if we have any drug that can speed up the recovery of the myocardium. I will come back on this topic, but of course, knowing a specific histology can help us to decide about immunosuppression. Generally, in severe cases of myocarditis, we use high dosage of methylprednisolone, 1 gram, 500 milligrams in pulses doses for 1 or 3 days. But there are specific cases like giant cell myocarditis where we use, for instance, thymoglobulin associated with steroids. While for eosinophilic myocarditis, generally high dosage of steroids are enough, and this is the same for sarcoidosis. While in sarcoidosis, it's relevant to associate a second drug in the long term with steroids. And for the immune checkpoints inhibitors associated myocarditis, it's important to hold immune checkpoints drugs and to start with steroids plus other very effective anti-T cells drug that could be thymoglobulins, like in my experience, or other rheumatological drug as abatacept that is used in rheumatoid arthritis. Like for lymphocytic myocarditis, there is pure, let's say, idiopathic or post-viral lymphocytic myocarditis. There are more doubts about what is the best treatment, because in most of them, myocarditis is related to an viral exposure, influenza, COVID. And so it can be there are different opinions about what is the best treatment, if it's correct to immunosuppress these patients or not to immunosuppress these patients and let the patient recovers and to eliminate the virus then likely cause the disimmune reaction. Of course, it's different in case of lymphocytic myocarditis associated to autoimmune disorders like lupus or other cause like antiphospholipid syndromes. So in that case, it's relevant to add a second immunosuppressive drug like intravenous immunoglobulins. But what we can say is that at present we do not have good evidence of efficacy of immunosuppression in this case like lymphocytic myocarditis. But in any case, it was the beginning of 2019 at that time, so we decided to start with a high dosage of steroids, and we have a really good outcome of this patient with a rapid in recovery of the left ventricle function. We perform the search for serum antibodies, and the only thing that we found at that time was that performing a nasopharyngeal swab, we had the evidence of a coronavirus. Not a COVID, but it was a coronavirus that can cause cold, common cold in general. And the patient was weaned from ECMO on day 6, and the day after she was weaned by balloon pump, and the immunosuppression was discontinued on day 7 and extubated on day 8, and day 9 was admitted in the cardiology ward. Then after 2 weeks, we perform an endomyocardial biopsy. There was evidence of edema, but in the end, the area of fibrosis was really, just in the inferolateral walls, and it was quite unexpected comparing with the severity of the clinical presentation. And the patient is alive after 5 years, no myocarditis recurrences, no need for any immunosuppression in a NIA class 1 with preserved ejection fraction. So we can move to the etiology, pathophysiology, and specific form of myocarditis that I have already discussed about a bit, and of course, what are the best diagnostic approach. So we know that around a large spectrum of myocarditis is caused by viral infection, between 20 to 80%. It depends if you base this diagnosis based on the presence of prodromal symptoms, or if you look and you search really the virus in the biopsy or in the blood or in a nasopharyngeal swab. But we can say that the majority of cases are related to the exposure to viruses. Then we have this new entity, and we need to take in account this new piece of information that is between 8 to 16% of patients with myocarditis has a genetic background, so a family history and specific pathogenic or likely pathogenic variants in genes like desmoplakin or titin. Then there is a less than 10%, around 7% of patients with an associated systemic autoimmune disorders. And you need to remind that you should remind that in some of these patients, myocarditis is the first clinical manifestation of a systemic autoimmune disorder. So you can make a new diagnosis of a systemic autoimmune disorders when you treat your patient with myocarditis. And there are specific cases associated to drugs or vaccines, and we know that this new class of anti-cancer drugs like immune checkpoint inhibitors are associated in 1% of severe myocarditis. So it is very relevant to this subpopulation, and we will discuss this subgroup. Of course, in countries like Colombia, myocarditis can even present as acute Chagas disease. And this is also the case for dengue infection that are both present in Colombia. So in my view, there are not good studies on that. So it could be relevant to further study how often the acute presentation of this condition can be associated with myocarditis and acute myocarditis. Unfortunately, some of these presentation can be really mild, in particular for acute Chagas or even for dengue. So it can be difficult to estimate the real prevalence of myocarditis occurring during the acute phase of these disorders. But of course, more studies on that are needed. Probably one of the best studies that I've noticed about the acute Chagas disease and the presence of myocarditis is from Colombia, but probably also more attention is needed for dengue infection. So, what is about the pathophysiology of myocarditis in relation with the viruses? So, we can use this CAP term of a virus-induced acute myocarditis, and then we can consider that virus-mediated myocarditis and virus-triggered myocarditis. Okay, this is opinion. This is not science, but is my interpretation or expert interpretation of the phenomenon. So probably there are viruses like Coxsackie, like adenovirus that can cause virus mediated. So they are cytotoxic for the cardiomyocytes, and these are especially relevant in the pediatric population. Then we have most of the respiratory viruses like influenza or coronavirus that likely trigger an immune-mediated lymphocytic myocarditis. So it's not the virus by itself that causes a direct damage at the injury at the level of the myocardium, but these viruses are not in the heart, they just trigger an immune response. And another important uh, piece of information to have in mind is that there are acute myocarditis and chronic inflammatory cardiomyopathies. Both these terms are called myocarditis, but in my view, they are different. They are different in terms of clinical approach, and they are different also in terms of a response to immunosuppression. So you can have acute myocarditis where generally the onset of symptoms is within 30 days. They can present as fulminant myocarditis. Left ventricle is generally non-dilated. If you measure troponin, generally is very high. If you perform a cardiac magnetic resonance imaging, you clearly see sign of edema, and if you perform a biopsy, you can find severe infiltrate or large diffuse infiltrate of inflammatory cells. On the other side, on the right side, you have the chronic inflammatory cardiomyopathies where likely symptoms are lasting for more than 1 month. Mostly, the most common presentation is heart failure. You can have mild increase in troponin. Left ventricle often is already dilated. If you perform a cardiac magnetic resonance imaging sequences and general edema can be more difficultly find on cardiac magnetic resonance imaging scan. And if you perform a biopsy, you can find inflammatory elements, but you can find already diffuse fibrosis. So these patients, we are not sure that respond very well to immunosuppression. This is another good review article on the pathogenesis of inflammatory cardiomyopathies. And in my view, the most important figure is this one, this Venn diagram where you have genetics, autoimmunity, and infection. They play together to cause a myocarditis in your patient. These are some clues to identify a patient with myocarditis with a desmosomal gene variant, in particular desmoplakin. So if you have a patient with a recurrent myocarditis, if you have a patient with presence of release of chronic troponin increase and between two different recurrences, and then you have a recurrence of a myocarditis without prodromal symptoms, without any viral infection, or maybe because he or she had strenuous sport activity and that cause a recurrence of myocarditis, or if she or he had a family history of cardiomyopathy, sudden cardiac death, or even family history of myocarditis, think about myocarditis in the setting with a genetic background. If you perform a cardiac magnetic resonance imaging, this patient, most of them, around 85% of them, had septal fibrosis. Septum is not generally involved in common myocarditis, where inferolateral walls are generally involved. And another characteristic feature is the ring-like aspect of the fibrosis, like in this patient. Other feature can be the recurrence of non-sustained ventricular tachycardia or high burden of premature ventricular complexes. If you perform a biopsy, most of the time the biopsy is not so informative. You can find more macrophages than lymphocytic, like in this case. And another important point is that patient with positive genetics comparing with patient without with negative genetics, desmoplakin has a higher risk of ventricular arrhythmias and in particular a higher risk of myocarditis recurrence with 60% of patients that 5 years after the first episode of myocarditis, they have a recurrence of myocarditis or they have ventricular arrhythmias. Then this other important mechanism of disease that is related to immune checkpoints inhibitors. This drug can enhance the response of T cells against the tumor, in particular against melanoma. But melanoma is the best model for the utility of these drugs that are currently used in more than 50% of types of cancer. So they are very frequently used. And in 1% they can cause this myocarditis. They can cause different kind of adverse events related to autoimmunity. They can cause hypophysitis, thyroiditis, colitis. So they can cause a dermatitis. So they can cause different and very severe cause of autoimmune disorders, but in particular myocarditis. What you have to have in mind is that this population generally is older comparing with other patients with myocarditis. The median age, for instance, based on the registries, above 60 years, and they are more likely if you have a combination of immune checkpoints inhibitors like nivolumab or pembrolizumab plus ipilimumab. And what is important is that they are most commonly associated with the use of PD-1 inhibitors like nivolumab and pembrolizumab. These are the drugs that you have look for. And another point is that they generally occur after 1 month from the starting of these drugs. So they do not cause a myocarditis after 2 days generally, but it takes time. Another point is that presentation with chest pain is not so common. So we have around 15 to 30% of cases presenting with chest pain, while dyspnea and fatigue are the most common causes. Have in mind that they can present with a normal EF. So EF of 50% can be present in 50% of patients with myocarditis related to immune checkpoint inhibitors, but they can present associated myositis with increase of CK. They can present with diplopia caused by myasthenia-like syndrome, and they can present with ventricular arrhythmia or advanced atrioventricular blocks that they cause the death of these patients. So have in mind that this is important. So checking for troponin, performing an ECG, be sure that there is no drop in the left ventricular EF is of paramount importance in these patients with a high mortality that can reach 50%. And of course, they have also cancer. So ECG is a key tool for the diagnosis of myocarditis. Generally, they present with an ST segment elevation, QRS widening, advanced atrioventricular block. Of course, presence of ventricular arrhythmias are markers of high risk. Among the laboratory tests, the key test is troponin. Troponin, natriuretic peptides. C-reactive protein can be increased, but is not so relevant. I mean, we see several patients without increasing C-reactive protein, but still they have a severe myocarditis. It can be important to check for a white blood count, in particular to check if there is a eosinophilia, because they can steer you toward an eosinophilic myocarditis. I suggest to perform a nasopharyngeal swab, not only for COVID, but also for influenza. Echocardiogram is the most important, together with the ECG and blood test exam, that can be performed almost everywhere. And in 75% of cases with myocarditis, EF is preserved. So it doesn't mean that you do not have a myocarditis, but of course, a patient with a decreased EF has a worse prognosis. And the coronary angiography or angio-CT is commonly used in particular in elderly patients or in patients with the cardiovascular risk factor. So around 50% of patients we admit with a myocarditis undergo a coronary angiography in the end. And what's about the choice to perform endomyocardial biopsy or cardiac magnetic resonance imaging? We generally perform in complicated presentation, where you have a drop in the F presentation with acute heart failure, ventricular arrhythmias, advanced atrioventricular block, or cardiogenic shock, we pick in particular a patient with hemodynamic instability, high degree atrioventricular block, sustained ventricular tachycardia, because these are not the patients that in whom you can perform a cardiac magnetic resonance imaging. They are unstable. So we suggest to perform biopsy, and this is a recommendation 1B for the American Heart Association, while in all other cases, if you are able to perform a cardiac magnetic resonance imaging, it's better to do that to confirm the diagnosis and to look at the extension, the pattern of inflammation in the myocardium. Of course, you can perform both. In particular, in severe cases, when you have the recovery from a ventricular tachycardia or after the acute phase, it can be useful to perform a cardiac magnetic resonance imaging. On the other side, if you see that on the cardiac magnetic resonance imaging, it could be suspicion for cardiac sarcoidosis, maybe it could be better to go back and to reconsider biopsy. This is just a list of these exams that you can find in my review article in JAMA, and this is my suggestion about the risk-based approach to acute myocarditis. If you have severe cases, are based on clinical presentation, blood pressure, heart failure, presence of heart failure symptoms, reduction of EF, or presence of sustained ventricular arrhythmias or advanced atrioventricular blocks. If these features are present, you have to contact and refer patient to a center, a hub centers with a VA ECMO service or facility. It could be important to have a service with a facility where they perform endomyocardial biopsy. It's not the case to perform a cardiac magnetic resonance imaging in these patients, even if it can be useful to have a scan before discharge. And you can consider to to administer steroids. While on the other side, you have the low-risk patients. These patients can be treated almost everywhere. I recommend to perform a cardiac magnetic resonance imaging to have the confirmation in a young patient that he or she had a myocarditis. And then you have the intermediate risk where you have maybe symptoms of heart failure, but the drop of EF is not so high. And you can consider to discuss maybe by phone your patient with the hub centers, or if you are the hub center, you can suggest to discuss with the spoke centers that they have in charge this kind of patients. If it's the case to centralize the patient and to perform a biopsy or not. Again, cardiac magnetic resonance imaging in these patients is recommended, and steroids or immunosuppressive drug can be discussed case by case. And then now, just the final remarks about the outcome. The mortality is expected between 1 and 7% of cases. In hospital mortality, if the patient or heart transplant, if the patient is complicated by left ventricle dysfunction below 50%, heart failure, ventricular arrhythmias, advanced atrioventricular blocks, or fulminant presentation is around 12%. While the mortality or need for heart transplant in patients with cardiogenic shock due to myocarditis had a 60-day mortality of heart transplant of 28%. And this is a number that is found at least in 3 independent registries. So this is the picture that you should have in mind. With an acute myocarditis, there is around 2.53% of mortality or need for transplant in the first 30 days. Then you have a flat curve and you have a residual 1% of risk in the following 5 years. Of course, you can have a sort of complete separation of two populations based on these complicated myocarditis criteria that I show that I presented. So it's easy to define who are the uncomplicated patients with low risk and who are the patients at risk. Of course, if you look at patients with the fulminant presentation, these are the very, very high risk patients with a very high risk in the first days of hospitalization. These are search for further markers that are associated with a poor outcome within the patient with a fulminant presentation, that means with the cardiogenic shock, and of course having a giant cell histology or a QRS duration of the above 120 milliseconds. So when you have a bundle branch block, are risk markers to have in mind. We are conducting a randomized trial, that is the MITS trial, and now we are assessing in a randomized fashion if methylprednisolone 1 gram for 3 days is effective in patients with lymphocytic myocarditis to provide new evidence about safety and efficacy of this approach. Of course, as I discussed, giant cell myocarditis can need thymoglobulins. We generally use 1 milligram kilogram like in the induction for heart transplant. Eosinophilic myocarditis generally respond well to high dosage of steroids. Cardiac sarcoidosis, they generally respond well to steroids. And of course, as I said, immune checkpoints associated myocarditis can be tough cases, and we suggest high doses of steroids and then to add thymoglobulins in very severe cases, or consider cyclosporin or tacrolimus, even if alternative treatment like abatacept are suggested by other experts. And then we have specific cases of autoimmune disorders can require cyclophosphamide, can require the use of immunoglobulins or mycophenolate. A specific case is the Lyme carditis that generally can cause advanced atrioventricular block requiring a pacemaker lead, and they generally respond very well to ceftriaxone or doxycycline. They generally do not require steroids, and in most of cases you can wean off the temporary pacemaker. So the future perspective, we are conducting this randomized trial. Now it's active in 35 centers in the Europe and the North America and the United States. We have randomized 88 patients. Up to now, we have 35 active centers, and we plan to complete the study by 2028. So we are still open to new centers that are willing to take part in the trial. So we are going to randomize suspected acute myocarditis complicated by acute heart failure or cardiogenic shock, left ventricular systolic dysfunction with EF below 41%, non-dilated left ventricle below 56 millimeter, increasing in natriuretic peptide, adult patients below 70 years, and recent onset of symptoms within 3 weeks of cardiac symptoms, ruling out acute coronary syndromes in patients that are older than 45 years. And another important point is that endomyocardial biopsy is not mandatory, but is based on the experience of the center. So this is the general overview. We have most of cases of myocarditis that are uncomplicated. Most of these patients can require just supportive treatment to relieve the chest pain, to reach the correct diagnosis. Among them, you can reach more complex diagnosis like the onset of an autoimmune disorders, or you can find a patient with a genetic background. Most of these patients has an eventful outcome in hospital outcome, like complicated myocarditis can require a care bundles, in particular in fulminant myocarditis. And the worst outcome is expected in fulminant myocarditis that are caused by giant cell myocarditis. This is my final slide. So the take-home message, in particular for fulminant myocarditis, is the early recognition. Refer from the spoke to the hub center. Aggressive, timely, circular supports. Do not wait for VA ECMO. Do not expect a cardiac arrest. Prevent cardiac arrest. Positioning an ECMO when the patient has high lactate, hypotensive, very tachycardic, so it's better to prevent cardiac arrest. And then B for biopsy. So perform endomyocardial biopsy in a safe condition as soon as possible to have a precise diagnosis. And C for consider corticosteroids. We randomize all patients that we can, but of course you can consider as a potential treatment corticosteroids. Thank you indeed for the opportunity to present my experience.